The thing, and we have to get this point across right at the start of this talk or we're in big trouble. And the thing we have to get across is all those patients who want something were taught by us to want it. They didn't wake up one morning and say, I'm going to go to the doctor and I want antibiotics. In fact, when they did the studies, they said that looking at people with colds, runny noses, and of course it had to be green snot, because that's what brought them, because it was green. Because if it had been clear, they would have been okay, but it was green snot that brought them. And the reason they came and said, and why did you ask for antibiotics? The number one answer, because that's what the doctor gave me last time I had these symptoms. So when we as a group say, well, the reason I'm going to give them antibiotics or I'm going to do this or I'm going to do that is because that's what they want, the reason they want it is because we told them that's what they should want. So that implies that if we teach them that's what they don't need, they'll learn that that's what they don't need. And it actually works. You can get people, as we found out with otitis, and Diane's going to talk about it in her talk, to not take antibiotics. You can get them, maybe not as extreme as me, to the point where I never give antibiotics for otitis media. So you can do it, you just have to reteach the people that we taught. And what's neat if you're in primary care is you have a captive audience. You have a bunch of patients who trust you and who are going to learn from you, and you can teach them over a period of time. And if you're in a place like I am in a town where we're the only emergency department in town, so this is how we treat things, guess what? That's how we treat things. And the patients learn. So in the flu thing, we're going to go through some articles here to talk about flu. And you're going to find out that one of the strongest people in favor of ceftriaxone, Larry Baraf, who is one of the most risk-averse people I know from UCLA, has actually come out and said, don't do anything. And he's the guy that championed throughout the entire 1990s fever, white count greater than 15,000, because there's a 1 in 10,000 chance of meningococcemia. You have to give ceftriaxone in the butt, because you better not miss that 1 in 10,000 case. Larry Baraf has said, don't do anything. So we're going to go through these articles. And of course, let's agree that we're talking about influenza, defined by fever, myalgia, severe malaise, plus minus a cough. Not the flu, like the public calls it, where they have the stomach flu, and they have the diarrhea flu, and they have this flu and that flu. So we're talking about influenza. To get there, we have to take a little detour. Okay? We have to figure out if they've got a flu and a fever and ache all over, is it just the flu or is it something else? So one of the primary candidates to give somebody an antibiotic is a red ear. So the first question asked in this chapter is, does otitis media cause a fever? So we're going to raise hands. Yes, otitis media does cause a fever. No, it doesn't. I don't want to say. Yeah. Whatever I say, Jim's going to lampoon me with something, so I'll just keep quiet. All right. You know, it's amazing if you look at all the protocols that were developed for the febrile child without a focus. Every one of them, otitis media is excluded as a focus. Think of it. If you have a little boil on your forearm, do you have a fever? And the answer is no. Well, there's got to be what? If you do have bacterial otitis media, there might be half a cc of pus behind your eardrum. So why would half a cc of pus cause a fever? And article number one there, a point about utility of history and physical exam variables that allow the diagnosis of otitis media. And Diane's going to go into this more on her talk on otitis media tomorrow. But let's talk about, in this chapter, talk about likelihood ratios. And for you to understand what likelihood ratios are, you have to understand that the likelihood ratio is, what is the likelihood that this measurement that I'm doing will alter my practice because it changes considerably the risk of something happening. So in other words, a likelihood ratio of a white count altering your judgment for appendicitis. Well, it would have to increase the risk of appendicitis by a factor of 10 or decrease it by a factor of 10 for it to actually mean anything to you. Now, lots of us don't know that and rely on tests that are of not much value at all to change our minds when it shouldn't. But it should be at least a factor of 10. So either likelihood ratio should be less than 0.1 or greater than 10 to show there's a 10-fold impact on the risk of something happening. If you take a look of likelihood ratios, even ear pain did not achieve this rating. And the likelihood ratio of fever associated with otitis media actually had no impact on diagnosis, a likelihood ratio of 1. In other words, no impact on diagnosis of otitis media. So whether they have a fever or not is irrelevant to the diagnosis of otitis media. Number 2, H-flu and pneumococcal vaccine era patients. This is what we're going to go through. You have to be very, very careful when you read the literature now in febrile kids to see what literature you're reading. Anything, as far as we're concerned, in 2006 that doesn't discuss kids in the post-pneumococcal vaccine era, you should ignore unless you're working with a culture that does not have the vaccination. Not just an individual, but the area, the whole neighborhood, the society, the culture, be it Native Americans, be it the Inuit population in Alaska and Canada that don't get vaccinated. Otherwise, an individual has herd immunity because everyone else around them has been vaccinated. So anything that's discussed in the 1980s, pre-H-flu, or in the early, before 2002, is basically moot discussion from now on. So you have to make sure when you read it, and that's important because there are studies being published now, 2005, 2006, that are actually data collected from 1998 to 2002 being published pre-pneumococcal vaccination. Basically, geez, it's published now, so this must be pertinent to what's going on now. In fact, it's not pertinent at all. So this has to be very carefully paid attention to, or you're going to get screwed up in what's state of the art. Today, in 2006, if I was to take a child with a fever and no focus, which is basically what the flu is, right? What risk are we running with that child to say anything other than, Mom, it's a virus? The answer is less than 1%. That it's anything other than a virus. If they don't look septic. Right? The toxic kid who looks toxic, you should be working up just like you work up a toxic-looking adult. But the child who comes with a fever of 104 and is running around the room, less than 1% chance that anything serious is going on with that child. The 1 to 2% blood culture rates, and to get you screwed up, if you do a blood culture on that child, there's a 3 to 4% false positive rate of blood cultures. So you actually got a 3-time greater risk of having a false culture than a true culture, and now you have to go work this kid up and do all these tests and dance down this road. So you're better off ignoring them. And in fact, if you take a look, Article 3 from Larry Baraf says it all. Mr. Risk Avoider, okay, has come out and said, fever, non-toxic, no source, and otitis is not considered a source, give them antipyretics, reevaluate at 48 hours if persistent fever, or sooner if clinical deterioration, no testing, no treatment. And there's no one in this room more risk averse than Larry Baraf. Okay? Question? No. No. That's all gone. No testing. Isn't that great? Mom, it's a virus. We could do a mantra of that. Say it a few times. Get you used to saying that. And then you could just from time to time change it up. Dad, it's a virus. If it makes you feel better to say something different. Number 4, another febrile child protocol. There's 4, 5, and 6. They're all just ones that have been protocols over the years that have all consistently said that otitis media is not the source of a fever. Oddly enough, despite all this literature, and we're talking about probably more than 100 articles at least, the good old AAP came out and said giving antibiotics for otitis media is an option except when severe, as defined by a fever greater than 38.5. You gotta love it. Because the AAP itself says in another guideline of fever without a focus, and in brackets, and otitis media is not a focus for fever. So the AAP has written 2 guidelines that completely disagree with each other, and they're available on their website at no extra charge. So what's the role of influenza testing? Well, what we've done, we sort of thought in our little brains, and we've been influenced by pharmaceutical companies and product companies, that, you know what, influenza is a bad thing. Influenza can kill you. And in fact, since you're not giving them antibiotics, what do you have to give them now? You got to give them an antiviral agent because, you know, it wasn't good enough that we gave them antibiotics. And now you're sort of learning that you shouldn't give antibiotics, so you have to give them something else. Of course, why do we worry about influenza? We worry about influenza not because of influenza. We worry about influenza because of the secondary risk of bacterial infection, otherwise known as community-acquired pneumonia. That's why we worry about it. Death from the influenza is almost inevitably from community-acquired pneumonia as a secondary infection. But our kids can't get the secondary infections. Why? They've been vaccinated against them. They've got the pneumococcal vaccine for all the main ones that lead to pneumonia. They've gotten the H-flu vaccination. They're leaking plasma for 15 months because of all the pincushion phase they've gone through. That's why we give them all those darn vaccines, so they don't get sick. Well, if the #1 complication is prevented by the vaccination they've already had, why are you worried about treating it? That's why you gave them the vaccination in the first place. So, you can ask a question.
What are actually the bacteria associated with influenza? Because I thought also like Staph aureus was...
#1 used to be pneumococcal. If you now look at the statistics now, Staph is statistically percentage-wise a high one, but that's because there's so little anything else around. But Staph is still very low. We're talking absolute incidence of only 1 or 2%. It's percentage-wise much higher now. But the absolute risk, it's like meningococcal meningitis, as Greg talked about, percentage-wise is much higher because there's so little of anything else. The problem in kids is that we're seeing less and less sick kids. So we know less and less how to deal with the ones who are sick. Yes?
There's a little caveat here that you didn't mention, and that is the presumption that the kids had his vaccination.
No, I said that right. So the question is a caveat, the presumption that they had the vaccination. No, I don't assume that. I said right at the start that if you're in a cultural group where there is no vaccination, then you have to assume that you're back in the pre-pneumococcal vaccination era. If you have an individual in a society that's already all vaccinated except for that individual, that person has had herd immunity, and the risk of them getting something serious is much lower just because everybody else has been vaccinated.
How long does the pneumovax last?
How long does the heptavalent pneumovax last? As far as I know, they don't know yet. They know it's at least 5 to 10 years. Because the old pneumococcal vaccine for the sicklers was 5 years. Yes?
The problem is if you've already not treated this kid appropriately, and you go to the pediatrician who flipped up tails this time, what's the antibiotic? That's where you get the complaints.
Okay, so the question is, I think this is a very valid question, because we don't work in isolation. We work actually in the emergency setting and in clinic setting. You work in a goldfish bowl. Everyone else sees what you've done. So the question is, yeah, but what about those darn pediatricians? You know what the pediatricians are saying? What about those darn emergency physicians? So what you do is you do what we do. You have a meeting together and say, here's what we're going to do based on the literature. Are you guys okay with this? If you're not okay with it, we're telling you, here's what we're doing as a group. You don't do this in isolation. You have to talk about it together because it only makes sense. So, I mean, that's, you don't, by all means, don't just go out and say, we're going to start doing this and screw everybody else. You talk about the limit to know why you're doing it.
That's okay if you're the only hospital in town. But the pediatricians you understand are different.
But then you know what? You can't solve the world. You have to start somewhere, and if you always use the excuse, well, someone else is going to say that I'm a dumb doctor, you know what? I'd hang up my shingle now because, gosh, there's probably half you think I'm a dumb doctor already, and I've never even taken care of you. So that I can't rely on that to stop me.
One of the risks would be giving the disease to an older individual, say greater than 65 or 75, and would treating finding out the child has the flu and treating that flu would decrease the...
Okay, so the question is, if you treat the kid with the antiviral agent, maybe someone who's old won't get the flu and get really sick, right? So the answer to that is, of course, by the time you've diagnosed the flu, they've been contagious for 6 days. So they've already spread it to everyone they're going to spread it to. Besides which, since there's a bunch of great primary care physicians in this crowd, everyone over 65 has been vaccinated against the flu. Right?
Not for treating, but I mean, one of the things we do is we do try to find out if they actually have the flu, and that's what their symptoms are from.
Right. So we're gonna talk about testing. We're coming to that. In fact, I just paid this guy $10 to ask me that question, by the way. All right. Rapid influenza A testing. Why do we do it? Answer, I don't have a clue. But we'll get there. This is from 1998 to 2000. Well, the study was published in 2002. It was from 1998 to 2000. So this is pre-pneumococcal vaccination. Age 2 to 24 months, temperature greater than 39, 65% had test results prior to discharge, 35% after. So in other words, we did some testing, but we didn't tell you what the results were. We were sneaky. If you knew the results, 2% got ceftriaxone, because remember, this is pre-pneumococcal. But if you didn't know the results, 24% got ceftriaxone, which boggles my mind. Urinalysis in 2% versus 24%. CBC 17%. You know it's the flu, and you did a CBC anyway. I want to congratulate that 17%. 44% if you didn't know it was the flu. Chest X-ray 47% if you did know it was the flu. 68% if you didn't know. That's kind of remarkable, you know, that half the patients who you did a test on to prove it was a viral illness, we then did a chest X-ray. That's kind of remarkable. It sort of begs the question, then why did we do the test in the first place if we're going to order a chest X-ray? And you can tell me, yes, the #1 complication of influenza is pneumonia. And if the parents tell me they've had the viral illness and all of a sudden, boink, they changed. Get a chest X-ray, absolutely.
That's not the way things happen in a busy emergency room. All those tests are ordered at the same time.
All those tests are ordered at the same time because we let them be ordered at the same time. We can't slough this off. And in fact, it shows that they're not all ordered at the same time because, in fact, there was a huge difference if you knew the results versus not knowing the results. So they weren't all ordered at the same time. Huh? The skeptics in the room. All right. 2003, from 2000 flu season. So endemic period, also pneumococcal vaccine was in place. 957 kids. No flu test versus flu test. 8% positive for the flu. Knowing it was positive, antibiotics were still prescribed to 33% of the kids. We did the test to prove it was the flu, and still gave 1/3 of the kids antibiotics.
Why?
Don't ask me why. Why do when doctors write in their notes that's studied by national surveys in the United States and Canada, when the diagnosis is URI, 75% of the time the person gets an antibiotic? Why? I don't have a clue why. But when we do a test specifically that proves it's a viral illness and still give 1/3 of them antibiotics, we should be doing some serious lint picking in our navels, wondering what the heck we are doing. Now, if you didn't do the test, or it wasn't positive, we're talking about a viral illness here. Fever, myalgias, I feel crappy. 2/3 of them got antibiotics. So you could say, well, see, that test is a great thing. We cut antibiotic usage by 50%. That's one way of looking at it. It is a one way of looking at it. Remember, for all comers, serious bacterial infection rates is less than 1%. So what are we afraid of that we're giving this many people antibiotics? Because the risk of serious bacterial infection is extremely low. The number needed to treat is 100. The number needed to harm is consistently 14 with antibiotics. Allergic reactions, diarrhea, etc., etc., etc. Number needed to harm. So you're harming 8 to 10 kids for everyone you might possibly help. Okay? On we go. Number 10, 418 with flu symptoms tested for A and B. Why are we testing for influenza B? It's a mild disease which has almost zero mortality. Who cares if they've got influenza B? Treating influenza B makes no sense. It's a benign illness with almost no mortality. Greater than 50% tested positive. If knew the child had the flu, less antibiotics, but not no antibiotics. But they compensated for that because they prescribed antivirals. So it actually cost them, the patients, more money to be diagnosed with the flu than to be just given an antibiotic, because the antibiotics are cheaper than the antivirals. Follow-up in this study in 10 was cut in half. Can you imagine if you had a rapid flu test in this hospital, you were in and out in 25 minutes? How many of you work in a dreamland like that? One? I certainly don't. Gosh. Number 11. I think you should read this paper only for you to see how dangerous publications can sometimes be. This is a dangerous paper because it was published in 2005, but you have to realize that the patients were collected in the 1990s. So this is pre-pneumococcal patients, vaccine patients, published in 2005 as if they were in the pneumococcal vaccination era. They weren't. They also didn't exclude kids under the age of 3 months in this study. Well, that's not fair because we know the perinatal sepsis rate is higher. We know the risk of serious bacterial infections under the age of 3 months is higher. So they talk about, we did urine cultures and we took a look at this in those who had bacteremia. If they were positive for the flu, they had a bacteremia rate of 0.6%. If they were negative, it was 4.6%, which is what it was pre all these vaccines. They also talk about urine cultures, 9.9% positive versus 1.8%. And overall significant bacterial infections, if you had a negative flu test, was 11.6% versus 1.8%. So they were trying to tell you that, you know what, you better do this flu test. Because otherwise there's a much higher risk of bacterial infection. But it's the wrong time period for us, and it included kids who should have never been included, which were the 0 to 3 month age group. Because those are still a different kettle of fish that have to be treated differently. But if you just read that article quickly, you would come away with the conclusion, geez, I better be treating these people, doing the flu test and treating these people because I got to know. How good are rapid screen tests? They're all pretty good, except you should know they're only about 80% specific. So there's a lot of false positives. Okay, there's a lot of false positives. Also, it's not 100% sensitive. The rapid flu tests are about 90 to 92% sensitive. So they're not a great test for sensitivity, and they're certainly not a good test for specificity. How do you know that? Because they compared it to serology. They did the serology on these testing. Yeah. That was a number 13 is a really good one if you want to take a look. So the question then arises, why then are we testing? Okay, so I'm going to give you some answers that come out of the literature that's there. One, these are WHO recommendations. WHO says In non-endemic periods, specificity makes false positives highly likely. So if it's not flu season, and you know it's not when it's hitting your area, and you're doing flu testing, you will have more false positives than you will true positives. So you're overdiagnosing the illness. And you're therefore going to prescribe something, if you prescribe something, to someone who doesn't have the disease. So the WHO says if it's not an endemic period, you shouldn't be doing the testing. Period. 2, if endemic periods, starting testing can heighten awareness. So in other words, if you follow the pattern, which is usually children start coughing, and they start getting cough-like illnesses 3 to 4 weeks before the adults get the endemic flu. So if you start getting your kids who are coughing a lot and you want to do testing to say, geez, look at that, influenza is now into our community, which is what we do. We do some rapid testing to find out if the disease is there, yes or no. Once it's there, we stop testing. Okay? We've established it's the flu. You've got the flu. Okay? It can also, if the kid's starting to get it, because usually the kids get it before the adults do, 3 to 4 weeks, if the kids test positive, that gives the primary care community a chance to say, geez, we got it, it's coming, we do have a flu season this year, and Mabel hasn't had her vaccination. And I can go give it. Or you can say, like in our community, if you're over 65, they give all the vaccinations in early October in the nursing homes. Well, they're only good for about 3 months in the elderly. And we didn't get flu season 1 year till March, so the vaccinations had worn off. So we started testing positive for kids in February. He said, Jesus, we are getting a flu season. It's too late. And they got revaccinated. Okay? So it does allow you to vaccinate certain people because you're just starting to pick it up. Maybe we can prevent these people from getting it. It's impractical to test everyone meeting criteria during endemic period. And remember, there will be routinely false negative tests. If you look at Articles 14, 15, and 16, they're absolutely nothing to do with this half hour, which is febrile workup of kids for the flu. And they just try and spin the old cost-effective analysis thing that if you do this or if you do that. And they come away with the recommendation that really if you're over 65, just treat everybody who's not vaccinated. They come with fever, myalgias, they're over 65, it's endemic period, just treat them. Sure, give Tamiflu to everybody. Why not? Put it in the water. The moral of this is kids who are vaccinated in 2006 are at risk for almost no significant bacterial illness. If they get the flu, so what? If you know that the virulence of a specific strain of type A is coming is stronger, the answer is very obvious. Vaccinate. In the elderly, vaccinate. That's the most cost-effective treatment. Not giving them Tamiflu, not testing them with an expensive test. The treatment is vaccination. But once you have a child who's in the endemic period who has flu-like symptoms, since they have been vaccinated, then don't worry about it. Let them be sick, don't treat them, and if they show any fall-off, their symptoms are here and they suddenly get worse, then by all means, investigate them. Do the chest x-ray, do the workup, find out if there's something serious going on, because you should be aware that the most common reason kids get pneumonia is because they had a viral illness first. That's what this literature supports, not routine testing and treating of everybody with symptoms. Time for a break.